Hello, everyone. Good evening, good afternoon, and good morning to all those who have joined us from different parts of the world. Welcome to another session of this AOCMF Global Study Club series, and continuing with the reconstructive surgery that we have scheduled for this month. The topic that we are going to discuss today is on injuries to the nerve, predominantly the facial nerve and the trigeminal nerve to go along with it. Our speaker for today is a very known name. He is Dr. Subramaniam Iyer, who is an alumnus of AIIMS New Delhi, where he did his training, and he went on to attain further training and honing of his skills at various centers in the United Kingdom, Mexico City, France, USA, and Korea. It's with great pride that I can say that for the last 20 years, he has been leading the Department of Head and Neck, Plastic and Craniomaxillofacial Surgery at Amrita Institute of Medical Sciences, Kochi. And he's also the president of the Eurasian Head and Neck Society and International Faculty, AOCMF. His areas of special interest is in head and neck cancer management. And another matter of pride that I would like to share with all is he led the team that did the first ever bilateral hand transplants in the country, and he leads the largest such program in the world. And he has won over numerous awards, delivered more than 200 orations and keynotes, and he's published more than 200 papers and trained more than 400 microsurgeons. Ladies and gentlemen, our very enlightened speaker, who's going to enlighten us on this topic is Dr. Subramaniam Iyer. To moderate this session for today, we have another, faculty amongst us, and he's Professor Dr. Mohammad Abdullah Zaim, who is an alumnus of the Cairo University, and he went on to do his MRCS from England and his doctoral degree in 2010. Of course, he's an AOCMF fellow. And in addition, he's been the adjunct member, AOCMF Community Development, since 2021 till now. He's also the member of the International Society of Aesthetic Plastic Surgery and European Academy of Facial Plastic Surgery. He has a special interest in minimally invasive and endoscopic CMF surgery. So thank you so much, Abdullah Zaim, for joining us and agreeing to moderate this event. And to join me on this session is again my own teammates, Dr. Najoo Jacob, who has been with us since 2020, since we started the Study Club series. And we also have on board, of course, our AOCMF staff, Sharing, and Inchwan and Shekhar Soman, who are also our team members and our background support. So without further ado, I would like to invite Dr. Subramaniam Iyer to please start the session for today.
Thank you very much, Yashasini. And thank you very much for the opportunity given to me to address you all. So I'll start without wasting time. I'll start sharing my screen. The topic we are going to discuss today is trigeminal and facial nerve paralysis, and basically an overview of its management issues related to it. And I have to say, so in this discussion, I thought I will bring to your attention and discuss about few basic issues met with the trigeminal nerve. I will be dealing with that in a very, very, very superficial way, only a couple of slides, so that we can concentrate more on facial nerve, which is of practical importance to multi-specialty type of people who are listening to this talk today. We will go through the anatomical aspects of surgical importance and management of facial nerve in parotid surgery is something a burning sort of issue with a lot of young surgeons. And then what are the immediate measures when facial nerve injured, and a glimpse into what we can do in establish facial palsy. As I told you, I'm not going to deal with too much about trigeminal nerve. I'll just devote a couple of slides. Maybe this is beyond discussion, beyond the scope of discussion today, more than that. And I have to say that my talk is type of a mixed one. In a way, it might be good for the younger trainees, and it might have some sort of interest in senior people to discuss more aspects of what I'm talking about. In the trigeminal nerve, mainly what I would say is a big nerve, one of the biggest cranial nerves with different branches, ophthalmic, maxillary, and mandibular branch, supplying the entire face. I mean, controlling the entire face, except for the facial expressions, which is the facial nerve. Of interest to most of us who are listening, I would say, practicing head and neck surgery will be the inferior alveolar nerve and the lingual nerve injuries, which you can come across in jaw fractures, or even it can occur after local anesthesia for dental extraction, then oral surgical procedures, orthodontic surgery, and even cancer ablative surgery, and endodontic procedures. And if you're using some endodontic materials or hemostatic agents, that itself can cause issues. As I told you, I'm just concluding this here that what are the real indications for medical management is as usual, observation and then symptom control. But the question comes to all of us: when do you intervene surgically in these cases of the inferior alveolar nerve and lingual nerve injury? If there is an evidence of nerve compression, to simply, to summarize the whole surgical management, if there is an evidence of nerve compression, immediate removal of that object, can be root stem, it can be bone fragment or implant. That is the key. That is the key. If there is a impinging thing, which you come to know by clinical as well as radiological evaluations. And if there is if you think that the endodontic material is the reason, then you may have to do an immediate washout or decompression of the nerve. Then if you have seen the nerve being cut, always try to repair it, especially in the lingual nerve. If it is possible, you can repair it very comfortably, because the lingual nerve is also quite lax. Unless you have done a segmental resection, you need not be worried about it. So if you witness a transection during surgery, try to repair it. And if it's a closed injury, this is the real sort of scenario which baffles most of us. There's a closed injury. Should I go in and explore? I have got references from a couple of, occasionally about should you do something. Repair if there is no improvement at 1 to 3 months for lingual nerve. That's a standard. It is not really dogmatic, but you can say at up to 1 to 3 months you can wait, or 3 to 6 months for the inferior alveolar nerve. Or if there is one patient, I still remember, the patient was complaining of severe pain at radiating to the area. In those cases, you might be able to go ahead with the surgical repair or decompression or whatever is needed at that time. Now, coming to our main nerve of concern today for today's discussion, the facial nerve. The anatomical aspects of surgical importance is very important for all of us surgeons. And now, this is the real structure of the facial. Yeah.
Subbu sir, if I may, I'm sorry. Yeah. Can we just launch a poll to know our audience better and see how many of them? Yeah. Can we just do that before we actually go into this after this discussion?
Correct. Yeah.
Yes, sir.
Please do. Please do.
So help us identify your specialty. Can you all see the poll?
I should stop sharing?
No, sir. No. Yes.
It has come. Yeah.
Yes. Help us know you better. So kindly vote.
If you have a couple of things.
With the small brief introduction, I think it's important to know how many of us are actually indulging in dental procedures and others. So. Okay. So, yes. So we have a majority of oral maxillofacial surgeons.
Plastic is 10, yeah.
ENT is 14.
Yeah, excellent.
Okay.
Yeah.
Right. So I have one more question just before we go into the the treatment aspects. How many of you practice the following for facial nerve injuries? Just medical treatment and physiotherapy? Or would you combine medical treatment, physiotherapy, and some static procedures? Or you would combine static procedures with reanimation? Or you would do all the three of above together with reinnervation procedures?
So yes, if you allow me, until with responses here, we can start the discussion with Sobo.
Yes.
With this, just a simple question, Sobo. When you mentioned the injuries of the branches of the trigeminal nerve, so did you see what's the common presentation that you see the patients after having an injury to these branches? Is it only the paresthesia along the distribution, or they can manifest with some degree of trigeminal neuralgia in this and other clinical presentations?
Mostly it is paresthesia. As well as some amount of paresthesia can be a bit of a troubling type of paresthesia in these cases. So it doesn't really amount to severe pain, but most of them say that they have different type of sensations. There is a lot of discomfort. That's the usual way they present. But you can also contribute to your experience.
So Azim, would you like to share what kind of presentations you usually encounter?
Well, that's this question. I sometimes see patients. They are coming and they're complaining of facial pain, and they had one day a tooth extraction, and then they had some or related to like what you have mentioned, of local anesthesia, which was followed by some complication like hematoma or severe pain after it, and then they develop some sort of facial pain. So the question here is it, can we correlate it to this, or we just say no, it's not related to this instance before? This was what I was just trying to share with you.
Yeah, I think it is a difficult situation. Most of the time it is difficult situation, and then the greatest problem is the practicing in that the person who has treated finds it difficult to convince the patient to wait. In these cases, if it is not clear-cut injury, I think amount of conservative treatment for 3-4 months in that way would be the ideal one. But many times it is difficult to convince the patient. So a second opinion might help. But again, the second opinion should be in a conservative sort of way rather than going into surgery.
Thank you so much.
Thank you. So, sir, if you can see our audience mostly.
I saw it. Yeah, maxillofacial. Yeah, that is good. That is quite good to see, because then we can discuss things that are all important. So anyway, it's a mixed crowd. So I'm sure what I'm going to talk will be interesting to all of them. So let me continue with the. Can I continue?
Yes, sir. Yes, sir.
So see, facial nerve is one of the most fascinating nerves of the whole body, because it's it is not really motor. It has got multiple sort of segment, and it has got a parasympathetic element. It has got a sensory element, and then it comes from different areas. I mean, 3 nuclei, and the course of the facial nerve is most fascinating, but it comes from the brain, go through the ear in a very tortuous way. I think it's a nightmare to the ENT surgeons who are doing ear surgery, and then it is a nightmare to head and neck surgeons who are doing parotid surgery. So it's something which, and also the maxillofacial, it's a nightmare to most of the people, because it can get damaged in a craniofacial procedure or a facelift procedure. So that's why it is most fascinating and good to know all about facial nerve. Now, yeah. it's not moving. Here. Now, the areas of concern, as I told you, in facial nerve is during facelifts, marginal mandibular, buccal, and frontal can be damaged. Then craniofacial procedures, surgery around zygoma, the frontal can be damaged. In the submandibular gland excision, you can have a problem for the marginal mandibular. And in parotid surgery, the main trunk or branches can be damaged. So these are all these branches can be damaged at various type of procedures we all undertake. There is some
annotations have to be.
Annotations are coming,
Yeah.
No, it's okay. Yeah. Okay. Now, let me, before I go into the anatomy of really facial, I just want to present few slides on the anatomy of fascia of the face. Arbitrarily, you can divide into three parts: neck, cheek, and temple. And it is divided by lower border of mandible, zygomatic arch, and temporal crest. And then there are two layers of fascia. One is the superficial fascia and the deep fascia. And the superficial fascia is, in the neck, it's the superficial fascia of the neck. In the cheek, it is called SMAS. In the temporal area is the STF, that is a superficial temporal fascia. Whereas in the deeper facial layers are in the neck, it's a deep cervical fascia and the parotid mesenteric fascia, as well as the deep temporal fascia. Now, why is it important? Because the structures follow a definite facial plane. Superficial fascia splits to enclose the muscles, which are the platysma, the facial muscles, and frontalis. We all have to be clear about it. And the deep layer of fascia is superficial to the muscles of mastication, salivary glands, and the neurovascular structures. Especially, most important is it is superficial to the neurovascular structures. Why is it important? Because the neurovascular structures, especially the nerve, is in the deeper layer, has to pierce the deep superficial layer. So that is where our problem occurs in all these surgeries. So if you dissect the fascia, dissect the face in the superficial fascia, it is the most safest one. But unfortunately, it will compromise with your blood supply. So you can't do that. Over the parotid, the deep fascia forms the capsule and the nerve is deep to it. And the muscles of the facial expression are superficial to it. So it has to pierce that in front of the parotid gland to go into the muscles. So, and then most of these nerves pierce and then innervate the muscles in the undersurface. Now, few things again. Upper division branches are thicker and more resilient, so you can be more comfortable in dissecting them. They take, unfortunately, a superficial route. Not, I would say, unfortunately, fortunately, because easier to dissect. The lower division branches are more delicate and more deeper placed. Especially the marginal mandible is much more deeper than the upper branches. And again, neuropraxia is much more common with the lower division because the flimsier nerve. The temporal and mandibular branches are the highest risk of iatrogenic injury. The reason is that if you look at the buccal branches, there is multiple branches coming together. So it has got multiple points of entry into the muscle, whereas there is hardly any cross innervation between the temporal and mandibular branches. That's why they are important to be taken care. Now, how do you take care of the facial nerve in the surgeries which we are talking about? In the taking care of the frontal branch, even though there have been this is a study which has been reported, which shows that this was a review of the all articles, which show that it is bit confusing to everybody. Everybody even now, exactly where is this nerve coming out? But in general, you can say that the nerve, it is about 2 centimeters above the zygomatic arch. It goes into the intermediate layer of facial So your dissection, you can have stepwise sort of cutting there when you come from above. That a lot of areas have been described. So, but think that around 2 centimeters above the zygomatic arch, you have to be very, very careful. In facelift, if you look at it, separates mass and superficial dissection is the safest because the nerve is under the smash, superficial is okay. Smash lift doesn't go beyond the level of the anterior border of the parotid, and the subperiosteal dissection is very, very safe. But that is very difficult, which we don't do. And also, whenever you do a smash plication, try to make it in the line of the facial nerve rather than across, so that even if you suture, it won't strangle the nerve. And most importantly, in a submandibular gland excision, see, we have seen, and the neck dissections, the commonest problem is the marginal mandibular part. See, if you ask me which is the branch of the facial nerve that is most difficult to treat if it occurs, is the marginal mandibular, because there is hardly any method to correct that is available. So how do you overcome that is by going under the fascia of the submandibular gland always and lifting it up and dissecting out for your neck dissection or whatever is that, because the nerve will be protected that. And more than that, whenever you do the temporomandibular joint surgery and all, try to make sure that the assistant doesn't pull it too much with vigor and enthusiasm from the top, because they wouldn't be really looking at where exactly you are doing that. Yashaswini, can I have the poll question 4 and 5?
Yes, sir. Okay.
These are all simple questions they are formulated. Yeah.
So the facial nerve contains motor fibers, special sensory, parasympathetic, all of the above, or only motor fibers?
These are all really basic, very basic questions. So apologies for the seniors, to be given these questions.
I'm sure they won't mind, sir.
It's just to keep interest running. Yeah.
So we have ended
85%. Yeah.
Yes.
85%. Excellent. Yeah. Yeah. Good.
And question number 5.
Next one.
One second. Can sorry. Can you see this? So the facial nerve branches run under the smash and over the deep fascia, under the deep fascia and pierces it.
Oh, I don't know. There is more questions in that.
Choices, no, sir. We are out of choices.
Yeah. I think you'd skip that question because.
And poll?
Anyway, go ahead. Yeah. Go ahead. Yeah. Okay.
Okay, sir.
Correct. Okay. Now, going on with the next part, that is the management of facial nerve in parotid surgery. I'm sure it will be of interest to many of you. I have put 3 questions here. One is to whether to sacrifice the nerve or not. That is a big question when you're doing parotid tumor surgery. Second one, most important, how do you identify the nerve? And third is what to do if it was cut or it needed to be cut, or if it was cut inadvertently, you had to cut it, it got cut, what will you do it? If you look at whether to sacrifice the nerve or not, it is aided by few things. One is the presence of preoperative paralysis or weakness, which will make sure that you will encounter with the nerve going through the tumor. So, or it is being pressed by the tumor. So in these cases, you can very well warn the patient that you may have a chance of damaging the facial nerve, and we will have to repair it. Then imaging, if the tumor is going in the superficial and deep lobe and in an infiltrative type of lesion, and FNAC shows that it's a malignant lesion, these are all indications which tell you to warn the patient that you may have a facial palsy. Extent of the tumor, type of the tumor, like salivary carcinoma or even adenocystic carcinoma, or a large tumor, which is a very large tumor. These are all telling you that please warn the patient that you may have a facial palsy. Now, the extent of the tumor and type of tumor, basic principle we follow is that if the nerve goes through the tumor, resect it. If the tumor can be dissected out, preserve it. Because anyway, if it is a malignant one, the patient will have radiation therapy. So it will take care of few microscopic disease cells which is in the around that. So if you can dissect it honorably, you can do that. And deep lobe tumor excision or doing a total parotidotomy may have a transient paralysis. This is a sort of thing which I tell each and every patient. They all ask. They all come for that fear of facial nerve. The only thing which I always tell them that, see, we will try to not sacrifice it if possible. But even if it is sacrificed, we will do something to repair it. Thirdly, I have to warn you that even if we don't do anything, trying to protect it can lead to a paralysis, but you need not worry about it. It might take about 2 to 4 weeks to return. So this is a standard dictum of sort of counseling which I follow to all my patients who undergo parotid surgery. How to identify the nerves? These are the 5 things. Follow the tragal pointer, follow the tragal cartilage to the deep end. It is a pointer, and then it terminates in the pointer. It is about 1 centimeter deep and inferior to that. Then trace the posterior belly of digastric and posteriorly. Then the nerve will be in the just deep to the upper border of the posterior belly of digastric. Thirdly, if you trace the anterior border of mastoid process superiorly, it forms an angle with the tympanic bone. The nerve bisects that angle. That is the tympanomastoid suture. Fourth is, if you feel the styloid process between the mastoid bone and the posterior border of mandible, the nerve will be just lateral to it. And lateral means towards you. And fifth one is that follow the terminal branches of the nerve proximally. So this is the thing. This is a picture which shows everything. The tympanic ring is there, and the cartilage pointer, you can see the nerve is about inferior, 1 centimeter inferior and inferior to the tragal pointer, and deeper to the tragal pointer. Tympanomastoid suture is here, and the mastoid tip and the digastric bundle. So these are all good landmarks. If you ask me, just the greatest sort of way I would do always is to follow the tragal cartilage to the tragal pointer. Usually, it is always the nerve is exactly in that point, 1 centimeter deep and inferior to it. So that is the one thing which I will take, along with the tracing the posterior belly of the digastric, and the nerve is immediately deeper to the upper border. And this styloid process business is quite scary because the nerve is lateral to it. So I wouldn't take it very seriously. So that is not that's not an ideal thing. Another thing of practical importance, whenever you come to that area where you have the facial nerve, just go dissect slowly. You will find the artery which is traveling exactly in the same direction. And if you happen to cut it, it will bleed. And then if you cauterize it, that is something which can cause a damage to the facial nerve. So just look for the artery, then bipolar it, and then if you dissect it deep, you will find the facial nerve. So, and following the terminal branches proximally, what branches you follow is mainly the marginal mandibular or the buccal. So this is very useful in recurrent cases as well as whenever the tumor is infiltrating posteriorly in the mastoid tip area where the nerve exits. So there, tracing the nerve from retrograde fashion will be better. Yashaswini?
Yes, sir. Question number 6. So after you have heard this, the anatomical landmarks for identifying the facial nerve include?
So Sobo, until we get...
Yeah, you can. Yeah.
Well, also, I want to invite everyone to share his comments and questions, and you can share it also live if you want, or you put it on the chat. And Sobo, what's the thing that you do when, or you can give an advice if you are approaching and searching to identification of the facial nerve, and then you find the area is bloody, and then you lose your orientation? How to get back and orient yourself back?
It's the first thing I always insist that a bloodless field is a must for me for parotid surgery. Big surgeries of neck and all, it's fine. For parotid, you need to have that bloodless field. So use the bipolar with caution, and then you should, even whenever you cut a parotid tissue, it bleeds. So whenever you cut it, and then the second point would be that you have to be slow and meticulous. Wait for that bloodless field. I would wait by pressing with a gauze piece with the adrenaline and whatever is that for 5 minutes to keep it controlled. Never work in a bloody field to find the nerve. You might not think so. Better wait and then control the bleeding and go ahead. That would be my way of looking at it.
Okay, and how to reorient yourself through navigation?
Now, again, the same thing. Here, all these marking points will be still there. The tragal pointer will be there. Your posterior belly of digastric will be there, and the tympanic ring. See, these are the 3 points which I like. Otherwise, if you are finding it extremely difficult, stop there, go to the front, find the marginal mandibular, come back. And that will give you an idea whether, or you can go even the buccal branch. Buccal branch is more safer in a way, and then come back and then you look at it. The buccal branch, the problem is that most of the tumors might need to be bisected for that. Bisected. So you don't, probably marginal mandibular and lifting it up will be the best.
So that's great points to be mentioned here. Thank you, Sobo.
Yeah. Thanks, Abdulaziz. So these are the results of your poll question for anatomical landmarks.
That's good.
Yeah.
Now, so we went through that. I mean, identifying the thing. Then what do we do if it was cut or thing? See, this I will combine with the next part. That what are the immediate measures when the facial nerve is injured? That's part of the main topic. It's same. Now, there are 4 things you can do in the nerve, about a facial nerve. One is the nerve decompression, nerve repair, nerve graft, and nerve substitution. I'll just take you through each of them very briefly. Nerve decompression is something which is done when usually it is done in temporal bone fractures. The ENT surgeons in the crowd will know about this. If there is a mastoid infection with a dehiscent facial canal, you can have a facial palsy because that is an urgent indication for facial decompression. And it should be done as early as possible and not later than 3 months. Approach is by a middle cranial fossa or transmastoid. See why there is a lot of confusion about whether you should do a decompression or not. Still raging sort of question of a question being asked by different people whether it is really beneficial or not. But generally speaking, if you have to do, if there is an impinging bone fragment pressing the nerve, it is better to decompress. And then you may need to approach the nerve through a middle cranial fossa approach, because it's a top part which gets sort of impinged by the fracture. Nerve repair is done when, imagine you have both the nerves cut and you can put it together. It is to be done. If you look at it, this is the best way you can bring back the facial function. Nerve repair with a micro sutures like 9-0, 10-0 sutures under magnification is the best. You cannot do it beyond the mid-pupillary line because the nerve just goes into the muscle. So try to repair any nerve if it is before that point of the line between the mid-pupillary and lateral canthal, between that line, you try to repair it. See, if the nerves cannot be approximated together, when I said that nerve repair is good, don't do it if the nerve is under tension. That doesn't work. So in those cases, when the ends cannot be brought together and it's just like this, put a graft between them. And then you can use sural nerve, you can use greater auricular nerve, all those things to do the graft. I'll just quickly take you through a small video where you can see the nerve being, this is a sural nerve which is fascicles, two branches, and then you can see that the micro sutures are being done for the upper branch, and the lower. Now immediately the lower branch will be sutured. So these are all sutures being placed there, and this is the lower branch being you can see the suture being passed. Couple of epinural stitches are enough to keep them together, and then I'll go to the end here where you can see the terminal, that is the main trunk is there, and then you are going to suture the main trunk. So the main trunk is being sutured back. So the sural nerve with two branches are being, one goes to the top, one goes to the lower, and then the main part comes. You always reverse the sural nerve because it's a sensory nerve. It just goes like that. So reverse it for the way it should work. And then let me see. I'll just want to show you the last part. This is the part where ends with the suture. Once you have this is the tissue glue which is being used. It has been used. Many people like it. I like it to use it. You just apply it around so that it forms a sealant, and then we use it a lot in all the brachial plexus surgery and all the facial reanimation surgeries. It works well. So I'll stop here. This was this video was taken by my colleague Dr. Deepak. The last thing you can do for the nerve is the nerve substitution. Nerve graft can be done when there are two ends. Imagine there is no proximal end. Imagine a case where acoustic neuroma has been done and you don't have a proximal segment to connect to. In those cases, what you do is to substitute another motor nerve into the distal segment of the nerve. You can use the contralateral facial nerve. You can take a nerve graft from the contralateral facial nerve and put it here. Or you can use the mesenteric nerve or hypoglossal nerve or accessory phrenic, C4, C7, all has been used. I'll show you. See, this is the full hypoglossal. This is a split hypoglossal. This is a split, again, mesenteric nerve. Mesenteric is the one which is common. This is a typical cross-face nerve graft. You take a buccal branch from the opposite side and tunnel it under the lip or over the lip and bring it and then connect it to the opposite side, cut facial nerve distal part. The only problem with the cross-face nerve graft is ideal because it gives a normal type of smile. When you wish to smile, the impulse goes from this side to that side. But the problem is the time taken for the axons to grow is 6 to 9 months. I know it's a problem. By that time, the muscles might get degenerated, and the amount of number, you are taking only a buccal branch, and that to go into the entire facial nerve of the opposite side, you might not find that number of fibers to trigger that sort of force in the muscles or the opposite side. So this is the mesenteric nerve is one of the commonest nerves which have been used. We all use mesenteric nerve. You find it about 1 centimeter below the zygoma and 3 centimeter in front of the tragus. You look at it. You can see that you can dissect out the nerve like this, and you can see the twitching. You just see the twitching of the face, and then look at the twitching of the facial nerve, and then distal part of the facial nerve, and you connect them together with the same sort of method, and it gives a reasonably good result. Let me show you some videos. I mean, this is the one. Let me see. Yeah. So you can see. So you can say that you get reasonably good sort of result out of that. Now, the other one is the hypoglossal nerve. Facial hypoglossal anastomosis was one which was described the first, and it was very good. And you can have a different varieties of doing that. You can have an interpersonal jump graft rather than cutting the hypoglossal nerve. You can have a mini hypoglossal, half of the hypoglossal cut and put it together. This is a facial nerve and a hypoglossal nerve. So it's so easy than mesenteric nerve to find the hypoglossal nerve, split it and put to the facial nerve. You can see a video of this guy. You can see the tongue atrophy, but it doesn't cause much problem. So you can see the tongue. So all these works, out of which probably the best would be the split hypoglossal direct or a mesenteric nerve. That's what we practice now. Yashaswini, can I have the poll question and maybe some comments from Abdulasim?
Yeah.
So, we have a question here.
Yeah.
From Dr. Hamad.
Yeah.
He's saying hello everyone, and he's asking about how much defect is required so that we go towards nerve graft instead of nerve repair. So what's the limit of the
my way of looking at it will be, as I told you, the nerve repair should not be under tension. If you feel that it is difficult to bring them together, don't do it. Put a nerve graft. Simple, it's a sort of thing. You might be able to mobilize the nerve to some extent so that they come together. You remember, you are removing the parotid gland, and then it might be lax, so you might come together, but it has to come together without tension.
Yeah, so it's about the tension.
Yeah.
Sharing, I'm unable to relaunch this. 1 minute, sir. I'm just trying to relaunch, but I'm not able to.
How much time do we have now?
Which question?
Now it's about 15.
Question number 7. Sharing question number 7.
Can you read the question?
Oh yeah, I can do that now. Yes. Something
okay.
was frozen. Thank you. Sorry. So this is for the audience. The following can be used when the facial nerve is injured. Yeah, I think that's straightforward.
So Hamad is replying now that he's happy with the answer and he got it now.
Okay.
So any more questions from our audience today? So Sobo, let me ask you a question about identification of the distal branches. So any advice when for the different branches to find the distal end during this if it was injured or the patient is coming with a facial cut wound?
Oh, no, I didn't talk to you about the use of nerve stimulators. You were looking at that. See, first of all, if you are an experienced surgeon, you might say that I don't want facial nerve stimulator. But I would say that be ready with a nerve stimulator. Simple ones are available. And most importantly, the anesthetist should be told that the patient should not be paralyzed. So they have to keep the patient without paralysis. The muscle paralysis doesn't, it doesn't allow nerve stimulation. So in those cases, it has been paralyzed. You can tell them to stop it and wait for half an hour. It will come. You can do the stimulation. So in case of doubt, use a nerve stimulator like what you saw in that mesenteric nerve. You are doing the nerve stimulator. So you do that, then you will be able to find immediately the muscles will work if it is a nerve. So to identify the distal branches, that's the best way to do that.
That's a good trick also. And we have another question here from Mohammed. He's asking, how much recovery can we expect after nerve grafting?
I would say nerve grafting is a bit dicey because of two junctions to cross. If I say nerve repair is 90%, this will be around 75%. 75%. Published literature goes between, it is a variable sort of thing, but it goes from 50 to 70, 75, 80%. So I would say inferior to nerve repair, but no. And if the patient undergoes radiation therapy for your malignant parotid tumor, this recovery will be delayed or might be absent also.
Okay, so if we can correlate both questions from Hamad and Mohammed, so a direct nerve repair under tension or a nerve graft with two
I would say always go for a nerve graft.
Okay, that's great.
That is better than the other one. Can we go to the next question?
Yeah, for some reason I'm not able to launch question 13.
Okay, fine. We'll skip that. We'll skip that.
Yeah, we can skip that. We can move on. So
yeah. Now,
okay. One more question here from
yeah.
We are having some more questions now.
Yeah.
He's asking, do we suture the nerves medial to lateral canthus? And I think this was mentioned before, so you can just
see, medial, no, because you don't find them. If you find them, you can. But many of the times it goes under the muscle and you might not be able to do that. What you could do is to embed this nerve into the muscle, if it's possible. The cut nerve into the muscle. Muscle neurotization also occurs, if it is possible. If you don't find the nerve, you just put it into the muscle and keep it, approximated.
That's excellent. So we can go on with your presentation.
So the next one is immediate procedures on the eye, which is a gold weight implant. It could be platinum fillers or fat, which is this is a gold weight which has been implanted, and then you can see this lady who has a gold weight implant doing very well. I'll just quickly go. This is a very short video which shows. So this is let me say, you choose the weight. You have a variety of 1.76, 1.8 grams, and put it on the patient and look at it. See, you tape it there and see how it works. If it then find the suitable one, and then what you do is to sterilize the implant and then use it under local anesthesia. You give an incision in that crease and then go to the tarsal plate, make a pocket under the this orbicularis over the tarsal plate very nicely up to the eyelash level. You can see that it's all going all the way there. And then in this pocket, you can see that the scissors is going all the way, and you are making a good pocket there, and put this gold weight, and then put couple of stitches to approximate the the muscles and then close it. That's it. So, Yashaswini, any luck with this question?
I'll try, sir. I don't know why I'm not able to. Question number 9. Okay, Sharing, I think you need to help me here, if you can. It says
Okay.
gold weight is implanted.
Yeah, it's a
Okay.
simple question. It's a simple question.
Can you
Just to see whether people are listening
Yes.
or not.
Yes, thank you. Yeah.
Let's see.
So also until we get the answers here, it's some surgeons they advise injection of some filler in the upper eyelid. The weight there is the weight.
Yeah. Hey, there is a bit of confusion there.
Yes, the audience are not very attentive.
Okay, now let me go. See, let me answer that question. You can use fat, you can use fillers, you can use platinum, you can use anything. It is inert. See, people. There are a lot of people who put in 1 gram, 2 ml of fat, aspirated fat, which also works, but it goes off gold weight also. But it is much. You can use anything. Anything doesn't matter. It's basically increasing the weight of the lid. Can I go ahead? I have some videos of interest.
Yes, please.
Now, long-standing facial parts. This is the last part, but it's slightly long. There are procedures on the eye, which is a temporalis transfer. It's of might be of interest. Second one is a procedure on the lower face. What you do is to take it around. You take a tendon or fascia or even the temporalis thing around. Let me go back around the eye, and then just above the lash inside, and then connect it to the medial canthal there, and then this is the temporalis muscle. You can see this video of this guy. You have to clench the teeth and close. You can see beautifully closing. With time, they tend to close in the night also very comfortably. And usually, you can see the small bulge there, which is there. And let me see. This is a small video. I think let me quickly see about that. And this is one way of doing it. So you take strips of the temporalis fascia with the muscle. I'm quickly because of the lack of time. So this is the muscle with the fascia which goes there, and then you tunnel it, and then tunnel it across, and then connect it to the medial canthal tendon in a scissor-like fashion, and then that's how it works. And this is the way it is sutured. Now let me come to the next one. This is another method which we have been using now. That was the older method. This is something which you can use a sort of anti-grade type of method. See, your exposure of the temporalis is much less in this. What you do is to expose the temporalis and then dissect onto the zygoma in that fat pad which you are talking about, and then under the zygoma dissect out the temporalis tendon to some extent. A small area of the temporalis tendon is cut and then lifted up, and it is lifted up, and now you use a facial lata or a palmaris and then connect this part of small muscle into the eye. This is the palmaris longus tendon being harvested. This seems to be better than the older method which you are using. So this is because the tendon is also good, and this is the way it is. You split the tendon and suture it there, and then you thread it across. That part goes into the medial canthus. This part goes into the medial canthus. There, and then you take it down and then bring it back. Let me see whether you connect it there, and then you connect it to the So this is thread like this. It all comes down like that. There, this side. And now the other thing also will come through this. We are threading it into this. And then is being pulled out. And then it's being pulled out. Yeah. Now you see it being sutured. See, you can see it is being sutured. And then you suture into that temporalis muscle, which is, see, this is where it is being sutured into the temporalis muscle. And so this seems to be better than the older way of doing that. So he's closing it nicely. Right. 8 and 10. I've got 5 more minutes, is it? Yeah. Okay.
Okay, sharing question number. I can relaunch this. Yes. Thank you.
I have a small video about the last part, which I'll try to show it quickly. So
the procedures to protect the eye in the facial palsy includes whole question answer.
I do apologize. I think, I said about it anyway. Yeah, all these things. Did I?
Let's see how our audience.
Let's see.
Yeah.
So, Sobo, we are having also a couple of questions here. Maybe they just be highlighted again from Pramila. In cross-facial nerve grafting, which nerve branch to choose from the normal side?
Buccal branch.
Okay.
Normally. Buccal, you can take 1 or 2 because buccal branches are multiple. So you stimulate the buccal and then see the nerve you take should be slightly stouter than a very flimsy one. So choose the buccal branch which is stouter, and then losing that won't affect the opposite side.
Mm-hmm.
And people have used the part of the zygomatic branch for the eye, transferring to the eye. But I would say that it is safer to use the buccal branch.
And actually, using the buccal branch from the normal side, maybe it balances the tone.
It balances also to some extent. Yes, correct.
And the other question from Mohammed again is he's saying, can you correct me if could be either a sensory or motor nerve graft? Does it make a difference? He means if you use a graft from a sensory motor nerve, I don't
know. This is the first time I have to start thinking about it because we have all been using sensory nerve always, some or other. We don't use the motor nerve because you don't know how it regenerates. Whereas the sensory nerve, it has been the standard practice. But it's a very interesting question. I'll have to dig out literature now about the motor nerve ever being used. What is the result? But usually it is sensory, always. Sural, greater auricular, or all those things.
Yes.
So it's also important that we kind of have a similar fascicular patterns of the nerves that we choose to graft, isn't it?
Maybe, Correct, yeah.
So, would you like to come throw your eyes on this answer? The audience is actually agreeing. Most of them, 83% agree that all these are ways of protecting the protecting the eye in facial palsy.
Yeah, correct. I would say,
Yes, and we go on to question number 10.
I got only 5 minutes. Yeah.
Sir, I'll give you time, sir. Sharing, could you help launch the question on temporalis transfer? Question 10.
And to add question
regarding
please say the question first and then continue the discussion.
Regarding temporalis transfer, it can be transferred only in a retrograde fashion, corrects the upper lid laxity only. Patient has to clench the teeth to close the eye initially, or it cannot be used for angle of the mouth deviation. Wow.
This is the most toughest question, I would say. I've done it.
Yeah, so regarding the question from Mohammed regarding using the motor nerve, not of a sensory nerve, I can say that if we can get the same effect with the sensory nerve, we are not going to think to sacrifice a motor nerve. So, and we can get long a long length. We can make it in a cable graft fashion. So I wouldn't think that if we can get what we want and we reach our target by using these sensory.
Yeah, correct. Yeah, that must be the right. Yeah, I think agree to that.
Subbu sir,
yeah,
your
last
comments
part,
on the
last
question?
yeah. Oh, that was okay, quite. I mean, acceptable. That temporalis transfer needs re-education. It corrects the upper and lower lid laxity. That's why it is superior to gold weight, because the only method that can correct the lower lid laxity and watering and all is the temporalis transfer. That's it. So that was it. Yeah. That is why it scores better than the gold weight. Lastly, procedures on the lower face. See, there are two things you have to think. I'm making it very simple for you. Trigeminally innervated muscles like temporalis and masseter, or a free flap. Masseter can be used. You can extend it with the fascia. You can see this patient with a bilateral facial palsy, smiling, clenching the teeth, but you don't use it much. The temporalis can be transferred like this, what you see in this photo, or more commonly as a Labbe procedure. There are a few groups who vouch for the Labbe procedure. We have not done much. It takes a coronoid process and extends it, and then if you see the results, it is fantastic. But the problem is that you cannot use the temporalis for the eye. You have to use it only for the angle of mouth. The eye will be gold weight or whatever is that. To me, that gold weight, the temporalis for the eye is more important than for the eye. That is the best. So I wouldn't sacrifice a temporalis for not for the eye. The last part is this free muscle flap. That probably the gracilis is the commonest one, motorized by contralateral facial nerve or ipsilateral masseteric nerve, or a dual innervation. Muscles which are being used are gracilis, latissimus dorsi, and pectoralis minor. But whereas the gracilis is the most commonly one, we tend to use latissimus dorsi occasionally when you have on the skin also. In those defects, you use that. So this is the way it is connected. You connect it to like this, and then this is a lady who had a gracilis transfer. You can see the movement, and this is another guy who had a gracilis transfer. And this is a young girl who had a gracilis transfer. So it works well. And then what is the difference between this trigeminal nerve muscles and this one? Free muscles, the excursions are better, but it's more complex naturally. The regional muscles are simple, but immediate benefit is there, but they don't have the real excursion. Select these methods as per the patient age, desire, motivation, all those things. If it's a very old patient, I might do a temporalis transfer or a masseteric transfer. The masseteric versus cross-face nerve graft for the see, single stage masseteric reinnervation is best because it gives immediate very good power, whereas the emotional component is not there, whereas a cross-face nerve graft gives that. Now, the latest one is a dual innervation, which we are all doing, where masseteric nerve will neurotize the muscle quickly, and at the same time, you take a cross-face nerve graft and put it into the muscle or into the nerve, so that the emotional component will come after 7-8 months. This is what we are trying to do now. Many of the centers are doing that. Can I quickly run through this video very quickly? I will do that.
Yes, sir.
This is that typical dual innervation type of thing which I said. So you Doppler the vessels, and then your incision is on the it's a parotidectomy type of incision, and you have to go all throughout that. This is the facial artery and vein being transected high up, so that you have enough length for the anastomosis. Then you mark this is the masseteric nerve that is being harvested. So 3 centimeters in front of the tragus, 1 centimeter below the zygoma, and you look at the nerve and then you stimulate and you see that the muscle is twitching. And once you get it, then this is the gracilis being marked. How much length do you need? And in this relaxed state, you put 1 centimeter type of sutures, so that when you cut it, you know that that 1 centimeter sutures will give you the real it will give you the real tension. So you don't take the entire gracilis, you take only a part of the gracilis, but making sure that the innervation is correct and the muscle works. So these are the points which you need, and then this is where it is being connected. So you put the stitches. What you do is to take the thick vicryl stitches, four numbers, and connected the modiolus, lower lip, upper lip, and the root of the nose. I mean, not root of the nose, at the ala of the nose. And then this is the gracilis being prepared. You can see the gracilis being prepared, like you put some stitches so that it will hold the vicryl together. So you split the gracilis into four quadrants at the end. You can see the vessel and the nerve, and you cut it, and then you connect them together on the top. So again, you put some vicryl stitches together so that it can hold the stitch. It is just being tied so that you can put the stitches together, stitches into the thing. Look, that previously placed stitches come behind this vicryl stitch so that it holds it together rather than tearing it. So you put all these four stitches together and push it into the cheek. So all these are put, and then it is pulled together at a go. So it goes there. Then you connect the vessel and nerve. So it is all done. This is the glue for the mesenteric nerve. And then you suture the proximal end to the thing. So this is how it is being done. And you take the opposite side, facial nerve is being taken. And this is the buccal branch, which you took for the cross-face nerve graft. And then you connect it to the sural nerve, and then this is a sural nerve that has been connected to the buccal branch, and then the sural nerve is now tucked into the muscle here. It is just for neurotization. I think I end here. You can have the poll questions, or I can just end with this thing.
I can ask, sir.
Yeah.
Okay. Free functional muscle transfer, nerve anastomosis can be two. Your options: contralateral facial nerve, mesenteric, hypoglossal, A and B, or all of the above. Okay.
All of the above. Yeah. See, the problem with my problem was that the hypoglossal nerve was not mentioned in my talk. But I have to say that the babysitter concept of dual innervation has come with the hypoglossal nerve. Even though we use the mesenteric and the opposite face, many people use the hypoglossal for the initial thing and then do the cross face. So all of the above is the right answer.
Sharing, can you help with the question number 12, commonest muscle used? I can do that. Thanks. So the commonest muscle used for functional transfer is latissimus dorsi, gracilis, pectoralis major, pectoralis minor.
At least there was a visual clue in my presentation.
So Sobo, after you have many ways for reinnervation and in late cases of facial nerve palsy, so how can you describe, how do you choose for each patient the suitable plan or the suitable technique? Does it differ from one patient to another? Do you prefer one procedure for all patients that works well in your hand? What do you usually do in your...
I thank you very much for the question, because this is the answer. I prepared. I mean, not full answer, but I'll elaborate on that. This is the last slide also. Anyway, so I know when you read about facial palsy, when you look at it or when you start practicing it, we are all confused about the amount of different methods that are available and use things. So you have to develop your own sort of, with your practice. You have to come to a conclusion. This is the thing which works with us best. So to me, our team, we would say that our algorithm of a facial nerve thing will be summarized in this slide with a few things which I'll tell you. Other things. One is the repair or graft if possible. That's the first thing. Whenever possible, do that. That gives the best result for your patient. So try to do that. In cases where which recovery can occur, like a temporary. You have a patient with a facial palsy sent by a neurosurgical colleague saying that they have kept the nerve in continuity in acoustic neuroma. Or when you also think that the nerve is this thing, there, if the eye is troubling, like the patient has a real problem with the eye, use a gold weight. This is very simple to do, and it can be taken out any time when the function recovers. In irrecoverable conditions, you are in a patient within 1 year of injury, you can use a mesenteric nerve transfer as a nerve substitution. You can add a gold weight for the eye if you want, because previously we all used to do a mesenteric nerve into the total face nerve. Then you clench the teeth, you close the eye and smile together. So that was a bad thing. So in those cases, what we are doing now, if you're selecting the mesenteric nerve, don't do it to the zygomatic branch. You do it to the lower branch, put a gold weight on the upper thing, or do a temporalis transfer later on to that. That works better. But this is the problem with this mesenteric nerve transfer. You saw all those patients. Their static nasolabial fold doesn't form. Only the smile forms. So that is a problem in older age. So in those patients, we might find it necessary to do a fascious sling also. But it is simple. That's why you resort to in older age group. If it is a delayed facial palsy, do a temporalis. There's no doubt about in my mind about for the eye, temporalis is the best, and do a mini gracilis, or if you are a fan of latissimus dorsi, you can do that, and you can do with the mesenteric nerve, preferably because it works very well. And you can do a cross-face nerve graft with a dual innervation if your time permits and your expertise is okay, and do that. That will summarize my. So in an older patient, my choice would be either, if possible, mesenteric nerve transfer with a fasciolateral sling if needed, or a temporalis or masseter muscle, sort of transfer. Whereas in a younger patients, obviously now the best thing is a temporalis transfer and mini gracilis or latissimus dorsi with a mesenteric or hypoglossal cross-face nerve graft with a dual innervation. That would be our policy. Yeah.
So that's great. It's a great summary for today's presentation. So do you want to add anything else, Sobo?
No, I think I've covered most of it. Any burning questions? I'm quite happy. That's all. Time permits.
Okay, so we have a couple of questions here from the audience, if you would allow. So, Yash, would you like to have this final question?
Yes, please. Yes, you can take the questions that we have.
Okay, so we have one here. It's from Mohammed again. He's asking you to highlight on the role of nerve conduits.
Nerve conduits? Nerve conduits are not really, I don't think we have used in the facial nerve, but you have used in peripheral limb trauma, where nerve conduits have been used and it has been found to be of use. But in facial nerve and all those things, no. One reason might be that these are all very thin and flimsy nerves, very thin and flimsy nerves. Whereas if you look at the median nerve or ulnar nerve, they are thick, they are big. So you can have, you can use them. No, I don't think no is the answer for this.
Okay. Another question is hypoglossal nerve evidence in facial nerve grafting. Not all cases are indicated. So he's asking you, please, sir, highlight or enlighten on this.
What was the question again? Facial nerve grafting?
It's hypoglossal. It's around the. It's for the hypoglossal.
Facial
nerve.
transfer.
Yes. Yes.
No. For the hypoglossal facial transfer?
Yes. Yes. Yes.
What is the thing? See, we are using initially hypoglossal facial anastomosis, or is it? Are you asking about hypoglossal nerve injury? No.
Yeah, I think I don't understand actually what's the question, but I can guess that it's about the use of hypoglossal nerve. It has an evidence in reinnervation for the facial nerve.
Yeah.
So,
it is.
What? How can you comment on this?
No. I mean, the hypoglossal was the first one which was used, and then it is being extensively used even now. Even now, we all started with hypoglossal nerve. It works very well. You have different types of hypoglossal nerve. You can split the hypoglossal nerve. You can cut the hypoglossal and connect the ansa back into that. You can use a jump graft. You can use the entire hypoglossal. So all sorts of things have been described, and it is even being used now. Like a lot of Julia Tersis has been publishing a lot about a babysitter concept about the facial transfer. You put the hypoglossal first, and then put the cross-face nerve graft, like what we use for the mesenteric and the hypoglossal. So it has a lot of evidence.
And one other last question from Edwin here is about the babysitting procedure, and how do you like anastomose or connect the cross-facial nerve into the gracilis nerve?
Yeah. See, this is a bit of confusion about with all the people. You read also, you do it also. There is a lot of confusion about that. See, you bring the cross-face nerve graft. You can put it in different ways. You can put it to the obturator nerve, that is the gracilis branch, and you can put it into that. You can put it into the muscle. You can put it into the into the mesenteric nerve part. All this have been described. What we have been using is to put into the area. You just put it in there, because there are excellent papers about muscle neurotization by with the nerve directly going to the muscle. So, but there is no dogmatic way you can put about it, because there's a lot of still not. It's still evolving sort of thing. Evidence is still evolving. How to put it exactly? We are using to put it into the end plate area. Just tuck it in there so that don't damage both, because all are flimsy nerves, and you can't cut a window into that and put it there unless the obturator nerve has a branch or fascicle which can be separated out. Then you can put it into it.
That's great. We have a lot of questions coming, and I don't think that we can
take all of them. Yeah.
We're actually 20 minutes over our time.
Oh,
Yeah.
Thank you so much.
Thank
so
you.
It was a fantastic talk and presentation as usual. And I think all the participants had enjoyed it and benefited from it. And me, myself, I enjoyed it very much. I had a great benefit from exchanging and sharing your experience with all of us. I would ask our participants that if they have these questions and more questions, they can communicate with you through the global group on my
AO.
And at the end, thank you so much, Yash, for inviting me and having me in this fantastic Global Study Club event. Thank you, Sobo, and thank you for the whole team. And Yash, please, for a closure for our wonderful event for today.
Thank you so much, Azim. I think you did a great job moderating this session so well. And Subasa, you were fantastic. We have got excellent comments in the chat box, so I've appreciated your talk as always. And I think those surgical videos were so so useful and so well taken. So thank you so much for sharing your views. I would request the participants to kindly leave your feedback and help us to do better with your feedback. And so before we wind up, as we are just waiting for the questions, I mean, audience to give the feedback. I noticed most of the crowd was also maxillofacial. So at what point would you recommend, and would you even recommend like the new age electrical stimulation, etc., as a therapy to consider in the time that there is some paralysis post surgically?
I don't know. This is also a burning question which doesn't have really scientific evidence now. VOC, as I told you, we are into the peripheral limb injuries and the hand transplants and all. There also is a raging question whether the electrical stimulation really helps or not. It's not resolved, but many people do it. And what personally I found is that in the facial nerve, in some congenital palsy, some of them, they have been regularly doing regularly doing the electrical stimulation. So that has been, okay. I think if you, nothing is lost by electrical stimulation. But will I suggest to everybody? No, I won't. But if it's available, that's all.
Okay, thank you. When I discussed this with the physio department, what they suggested is when you give electrical stimulation, you're actually giving stimulus to all the branches. And sometimes when only one or two branches are involved, it may not be the best thing to do. So to wait it out is what they actually suggested.
Oh, I'm talking about the total facial palsy, and then when you are recurrent. But in branches, I don't think it is not good. It's not good. It's not good.
Right. Thank you. I would like to request the team, the moderator and sir, to just hang on to the session for the quick debriefing before we can sign out. Thank you, participants, for being with us. So I think most of them have actually rated this as an excellent session and a session that they would definitely recommend to others. So thank you so much. Sharing, could we just end the meeting for the audience now? And
yes, I'm removing the participant out of this room. Please wait a moment.
Yes. Thank you so much, everyone, for joining us. Thank you. I hope you found the session very, very useful. And thanks, Abdulazim. That was a very nice discussion, very relevant points that you picked up and discussed. And thank you for sharing your views too. And Subasa is amazing, very nice. Ajusa, kindly stay back. Thank you. Yes.
Yeah, I have nothing to add. Subbu, as usual, was excellent. Dr. Aziz picked up the questions very, very well. And there are so many questions. I don't think we've ever seen so many questions in the poll, in the chat box before. And we're sorry we couldn't answer all of it. But I think it's a very interesting topic. And maybe we should go one step deeper later and go more into it. I think that went very well. Thank you all.
Thank you.
Thank you, Arjun.